Wonderful. Okay, it sounds like we are live and our webinar is now in progress. So a very warm welcome to all our audience members and thank you for setting aside time to join our APMEN Tech Talk today. By now you probably know that APMEN stands for the Asia Pacific Malaria Elimination Network, and it is a not-for-profit organization with a mandate to support the malaria elimination objectives of the 22 member states across Asia Pacific. And APMEN partners with the Asia Pacific Leaders Malaria Alliance, APALMA. So the two, APMEN and APALMA, work very closely together. They're headquartered in the same building in Singapore, and they support the 22 member states to work on malaria elimination. Our webinar today is going to focus on vector control in complex situations. And we're very fortunate to have three experts to share their insights with us. And we thank Dr. Xiaohong Li, Dr. Prayut Sudatip, and Dr. Pradeep Srivastava for generously giving of their time in preparing and presenting these talks. We're very grateful for that. Thank you sincerely for your time. Just briefly, some comments on the webinar process. We usually have our presentations all back to back, saving all the questions for the end. It's going to be a little bit different today. Dr. Li has to leave us, unfortunately, after about an hour for another commitment. So we will first listen to Dr. Li, to her presentation, and then allow time for her to respond to any audience questions. Then we will have the other two presentations back to back and have a joint Q&A session for those two talks right at the end. I would like to ask our audience members to please insert your questions in the Q&A box, not the chat box, please. We will only monitor the Q&A box for questions. Please remember that. I suggest you precede your question with the name of the panel member that you would like to respond to your question. For example, Dr. Pradeep, and then write your question. After the final Q&A session, there's a very short poll. It'll come up on your screen. It's very quick, 1 minute of your time, but it really helps us. And I'd be grateful if you could just quickly tick the boxes in that poll. Thank you for that. Very short. Please note that this webinar is being recorded and it will be made available on the Aureen website within a day or so. And details of the website will be made available on your screens. Okay, enough of me talking. Let's move on to our first presentation, except I haven't quite finished talking, sorry. This will be on the topic of border malaria, defining the problem to address the challenge of malaria elimination. And it will be presented by Dr. Li Xiaohong. Dr. Li is the technical officer responsible for certification of malaria elimination in the Global Malaria Program, GMP, of the World Health Organization. Since she joined the GMP, Dr. Li has led the establishment of a new certification mechanism, including setting up the Malaria Elimination Certification Panel, which is a technical body dedicated solely for the purpose of certification. She's the focal point for border malaria in the GMP and has led the work of an evidence review group on border malaria to establish strategies and guidance to support affected countries. She's also a focal point in capacity building for malaria elimination, including developing training modules for countries that have embarked on elimination. Before she joined the WHO GMP, Dr. Li had been working in the WHO country office in China and was responsible for malaria and neglected tropical diseases. She also worked at the National Institute of Parasitic Diseases, the Chinese Center for Disease Control and Prevention. So, Dr. Lee, again, thank you for participating in this webinar. I have no doubt our audience is going to enjoy listening to your presentation. Over to you. Thank you so much.
Thank you, Leo. Let me share my screen.
Thank you for that.
It's not now in full screen mode.
It looks like it is. To me, it looks full screen. Thank you.
Okay, thank you. So good morning, everyone. My talk is going to focus on border malaria and how do we define the problem to address the challenge for malaria eliminations. So border malaria or cross-border malaria is often cited as a challenge for malaria elimination. Many malaria eliminating countries often find their last few transmission foci near the in the vicinity of international land borders. Now I would like to give you some hard data. So we have been working on these border malaria issues since the Global Malaria Program and established the elimination unit and dedicated on malaria elimination. And that has been one of the area that we have been working on. Recently, we have looked at more closely to see whether the last few transmission foci of malaria eliminating countries truly occur in the border areas. So the first cohort of countries we are looking at is the E2020 initiative. And this is a global elimination initiative. It include 21 countries, and the cohort of country that we established this initiative in 2016, and this group of country and was considered as the whole potential to achieve elimination by 2020, and they are called E2020 countries. So of these E2020 countries, 19 of them have international land border shared with their neighboring malaria-endemic countries, and 14 of them had the last few malaria transmission foci along the international land borders. And this E2020 initiative has transitioned into E2025 initiative. Similarly, of the 22 countries that have international land borders, 19 of them find their last few transmission foci in the vicinities of international land borders. Now, this phenomenon is not only found in the contemporary malaria eliminating countries. We also look at the data from the historical from malaria eliminating countries in history. So we have looked at all the certified countries, and 22 of them, and we certified 43 countries and territories so far as malaria-free since the start of the certification program in 1950s. 22 of them share international land borders with others, which means a lot of countries that are certified are island countries. And again, we found a majority of these countries and have the last few transmission foci also in the vicinities of international land borders. Recently, I think it's in last year, a study compare and analyze 42 successful elimination programs and look at their trajectory. And they found that the countries that have international land borders generally eliminated malaria more slowly than island countries. So the challenge of international land borders for malaria is a challenge that we should recognize. Before we discuss why borders often represent the last mile of malaria elimination, let's be on the same page. What do we mean by border malaria? So in 2017, and as a response to countries' need to address their problem of malaria invasion at their borders, we convened a working group meeting here in Geneva, and we spent 2 days just to discuss what is border malaria. And subsequently, we convened the evidence review group on border malaria. We look at the evidence data available. We commissioned 5 case studies on border malaria across the globe. So this is what this is one of the outcome of this working group meeting and the ERG on border malaria, the definition of border malaria. So border malaria is defined as malaria transmission or the potential for transmission across or along shared land borders between countries where at least one of them has ongoing malaria transmission. Note that this definition avoids to provide a precise distance. So we don't say it's 500 meter, 1 kilometer, or 25 kilometer, recognizing the operational differences in affected countries. It delimits the geographical scope of border malaria to areas in the vicinity of international land borders. This means in malaria importation in interior areas, for example, several hundred kilometers away from the international land border is not border malaria. And it also excludes malaria importations through sea borders or airports. And that means island countries do not have a border malaria. So this is just for us to have a common definition of border malaria. Otherwise, it's very confusing. People talk about border malaria, but we are meaning different things. Now, why does border often represent the last mile of malaria elimination? So this is a complex question. We have to start from the history of malaria. To speak of the history of malaria is to speak of the history of mankind. I'm sure you have heard a lot about how malaria has shaped the civilization history of mankind. For example, the collapse of the Roman Empire it is said that it has something to do with malaria. So our ancestors chose to leave the place and they can did agricultural activities, and that's suitable for human to inhabit it. And these places where the human settlements established earlier, the civilization started earlier, becomes the central area. And on the contrary, those areas that are not suitable for human to live, to settle in, becomes remote area and periphery area. This is just to give you one example, the state of Israel. The boundary of the state of Israel corresponds to the boundaries of the severity of malaria in the Palestine area in 1920. So I'm showing 3 maps in this region, in the Palestine region. The boundaries of Israel coincide with the boundaries of malaria severity in 1920s. The Jews came to this land and they eliminated malaria and make it more inhabitable, and born the state of Israel. And because the nicer land, the land that didn't have a so severe malaria, was already occupied by the Arab who already settled way before the Jews arrived. So just to say that the border is actually a footprint of the interactions between malaria, human, and environments. So in other words, these border areas is actually has a higher intrinsic malariogenic potential, or we call it entomological receptivity. Why this is important? Because entomological receptivity or the intrinsic transmission potential is found to be the biggest challenge to achieve malaria elimination. Therefore, if an area have higher entomological receptivity, it is more difficult to malaria and to achieve elimination. So this is not just a simple statement. We convened a senior advisory group on malaria eradication just a few years ago, and we have a group of experts who doing modeling for WHO to see where will be the hardest place to eradicate malaria in the world. And one of the findings is that the place that have the highest intrinsic malariogenic potential and entomological receptivity will be the hardest place to eliminate malaria. So, and another example is these that we have many border areas happen to be the forest area, right? So like in the Greater Mekong sub-region and the border areas and often forest area in the Amazon zone, and it's also forest area. So the Anopheles there are like Anopheles diarrhea, Anopheles daringi, they are more difficult to control and with current tools and intervention, which make these receptivity higher than in other places. And the second characteristic of border malaria is the social and economic development and political unrest in border areas. Border areas are often the poorer areas, and actually many of them are the poorest. For example, in Iran, the border area with Pakistan and Balochistan in Iran is the poorest province. In Mexico, and a country also has a very typical border area, the area bordering Guatemala is also the poorest state in Mexico. And the northern district in Namibia and bordering Angola is also the poorest area. So why border area is often the poorest area, that's also very complex. And for example, it might be that this area is neglected for development. This area happen to be a remote area, and there are conflict and political unrest in border. Now, the social economic development that has a negative impact on disease elimination is not only unique to malaria, it also happen in other diseases. So we saw a problem for elimination and of other diseases in border, like smallpox, polio, and other neglected tropical diseases. They all have challenges for elimination in the border areas. But for malaria, because the economic development is found to be the largest driver to decline entomological receptivity, therefore, this low status of social economic development have a more prominent impact on malaria elimination compared with other diseases. And lastly, we have cross-border movement in the border area and the challenges of implementing the malaria programs. The characteristic of such movement in borders, and which is different from the movement to interior countries, interior areas, it's often short-term, it's frequent, it's cyclical, and a lot of back and forth. People often have their houses in the other side of the border. They go to school in the other side of the border, or just cross the border for better health care. So they form a border community. So from an epidemiological point of view, the two sides of border form a shared focus or a shared transmission zone. The ecological condition is the same. There has been a frequent missing of people, parasites, and vectors. However, international coordination is often challenging because the sovereignty, although these two sides of border form a shared focus, a transmission zone, but it's under the governance of two different political entities, and each have their own health systems, have their own priorities and development agenda. So because this webinar is about vector control, so I would like to focus more on the vector control issue. So what are challenges of implementing vector control in border areas? These are some of the challenges that we found in malaria eliminating countries. First, whether these vector controls is accessible to them, whether they can afford them. We are speaking about availability, and whether the at-risk population use them, utilization of the vector control, right? Because the tool is not perfect. And for example, in this warm and humid and climate area, and people do not want to use the bed nets. And also, and as already mentioned, the shared transmission foci or shared transmission zone, and it will be more optimal if the vector control can be synchronized to achieve a better outcome, right? But there has been challenging it to coordinate and the two sides of the border to take the same actions. And because the border areas is also a complex political environment, and as I already mentioned, they have the health system is weak, the capacity in the peripheral area, in the border areas is low. And also, we don't forget that the current vector control tools are not so effective in controlling some vectors, and including those in border areas. And these all contributing to the challenges of eliminating malaria in borders. So every border is unique, and one border is different from others. Their challenges also different. Their problems also different. As a starting point, we recommend country to conduct a situation analysis to look at what is the problem, where transmission occur, what is the geographical boundaries of transmission. For vector control, and just propose something to trigger the discussion to define your problems and of implementation of vector control in border areas. Who are at risk? What are the barriers of the at-risk population to access to vector control? Whether the vector control is quality assured, because when we talk about elimination, we need the quality of implementation. Whether the international coordination is essential and critical. And finally, we need innovations in vector control too, and we need to have the social economic development. We need to improve the people's life, including those in neglected areas, and so that we can shorten the long tail of elimination and to accelerate malaria elimination. This what I just walk you through is come from a paper we just recently published. If you are interested, and I recommend you to read through the piece, and we just published in Malaria Journal. Thank you.
Dr. Lee, thank you so much for a very, very, very interesting and important presentation to explain, and you explained it very well, very thoroughly, very meticulously, very calmly, so that even I can understand better. So for that clear explanation, I think everyone is very grateful, and I think we all learned from your presentation. Thank you for that. So there are quite a few questions, and I'm just going to go from the top of my screen. After international travel and trade border, malaria definition should be revised. We are getting many malaria cases from Central Africa every year without any border sharing with India. That's from Nilam Somalka. And I think you did point out in one of your slides, Dr. Lee, that it's separate issues. Imported malaria is something different to border malaria. Do you maybe want to make a short comment on that question? I think you did explain it during your presentation already.
to differentiate the malaria importation from border malaria? Is that question that you would like me to expand a little bit?
Yes, yeah, because the two are very separate issues.
Yeah,
So, yeah, all right. And she makes
yeah,
the point that, it's not border between two adjoining countries. It's actually cases being imported from
other countries.
Africa, yeah,
Yeah,
a completely different continent.
yeah,
And the definition of border malaria should therefore be changed to incorporate that. But you did make the point, there are actually two separate issues. Please
yes.
explain. Yeah.
Yeah, thanks. So, and why do we when we want when we when we talk about the need to differentiate border malaria from importation, we are thinking about interventions. So their interventions are not the same. Malaria importation and the border malaria are not the same. For malaria importation, malaria importation is to be expected because nowadays people move a lot. It is expected, it's the sole responsibility of the concerned government to manage malaria importation so that an onward transmission is prevented, right? So importation can occur anywhere in any countries and including in interior areas or not interior areas. Countries can have thousands of imported cases. They do not have onward transmission. For example, in one county in China bordering Myanmar, one county have 1,000 imported cases per year, and they can still maintain zero. It's the sole responsibility of the government. Now, border malaria, it often implies a component of international coordination, and sometimes it needs joint actions in the border areas. So that's why we need to differentiate these two things. Thank you.
Wonderful. Well explained. Thank you. So we're going to take a couple more questions relating to your presentation, please, Dr. Lee. Here's one from Sawadee Professor Jetsamon. Nice to see you joining the presentation. It's from Professor Jetsamon Prakrumsri from Mahidol University. What is the measurement to show malaria is limited to the country to be certified? Which diagnostic measurement is used to declare for no more malaria transmission in the country? So I'm struggling to interpret exactly what you mean, Jetsumon. If you're able to, do you want to activate your audio and ask the question? Are you able to do that? Otherwise, I'll just ask Dr. Lee if she can try and respond.
Well, I think, can you hear me?
Yes, wonderful. Welcome aboard,
Yes, it
Jetsamon.
is very simple. I think we have talked about malaria elimination for many years in the region during the technology developed. So my question is that what is the definition of malaria elimination from the country? No more cases, no more transmission, or which method the WHO, because now Dr. Lee, you just mentioned that you have special committee, right? Working on the elimination, the concept of elimination. I want to hear the latest outcome. What is the measurement to say that the country is already eliminate malaria?
Thank you.
You.
Thank you, Professor Jetsamon. Please respond, Dr. Lee.
Okay, thank you for that question. So I think your question is about certification of malaria elimination. And we have a whole WHO publication entitled Preparing for Certification of Malaria Elimination, which speak about I think will answer your question very thoroughly. Now I just give you just a few words very briefly. So the elimination we define as 3 years, zero indigenous cases for at least the past 3 consecutive years through a robust surveillance system. That's what we mean elimination. So to certify a country malaria-free, countries need to provide evidence to show that the malaria interruption has been achieved, resulting in 0 incidence of malaria indigenous cases for at least the past 3 consecutive years.
So that means the surveillance can be done by the most sensitive tool like molecular surveillance, or just the typical blood smear or something like that. I think this is the thing that every meeting that I join in person, you know, a few years before COVID, I asked the WHO team this question. So the robots, I know that it have to be clean for malaria for 3 years, but how you define there is no more malaria in the country?
So
yes.
The methods we recommended for surveillance of malaria is microscopy and conventional RDT. So we did not recommend the molecular tool for surveillance for malaria. So malaria certification doesn't mean that you need to have free of infection in the community, and you still will have imported cases. There could be some very low density of infection that you cannot detect that with the RDT or microscopy. But for those kind of infection, we cannot interpret them. We don't know whether they cause a malaria transmission. They probably not. So that we stick to these the cases detected by RDT and the microscopy, and that's what we recommended for malaria surveillance.
I see. And if we have monkey malaria, only monkey malaria, do we still can get a certificate?
Yeah, that's another complex question for certification. And yes, so we noticed that in recent years, there's an increase of noocyte cases in some countries in Southeast Asia. So what we said is that we will stick to the certification criteria, which is the interruption of transmission of four Plasmodium species. Then we mean falciparum, vivax, ovarian, malaria. For countries that have noocyte transmission or other zoonotic malaria, we require that it cannot have like it cannot be a public health problem, that the risk of infect the zoonotic malaria in that country is to be negligible. Now, this is a topic not specifically related to my talk on border malaria. It's a whole thing on certification. But you mentioned that I can just give you some brief background on the certification. The certification related to a register called Official Register, which was established by WHO through a World Health Assembly resolution. So the official register, and after countries certify, the countries enter into this official register. The official register is related to travelers' health. And that was the original purpose why WHO established the official register, why we have the certification process, just to ensure this area, when enter the official register, they have no risk of malaria, meaning the people travel to their area, they have no risk to infect malaria, and the countries that certify, they are not expected to export parasite to other countries. And that for that purpose, that WHO established the official register under the request of its member state. Now the noocyte issue, the zoonotic issue, is a complex, different one, and we still do not define how to certify countries with more noocyte transmission. But this is something that we are working on. Thank you.
Thank you very much. Very clear. Thank you.
Yeah. So I mean that's a whole webinar in itself. That whole subject of zoonotic, and we did have in December last year, we had a whole webinar devoted to simian malaria. But Malaysia is in that invidious position. It has not had any local transmission of the 4 human malarias since 2018, which means it surpassed the 3-year mandatory period. but it's got too many null-eye cases, and therefore WHO is not registering or certifying Malaysia as zero local transmission. So poor Malaysia is in a very difficult situation, but that's a separate topic. Thank you so much for the question. Very interesting, Professor Jetsamon, and for the good response, thorough response. Thank you, Dr. Lee. Yes, the last question, because we really need to move on to the next speaker. Shubla Singh asks, so as per definition, the inter-country malaria between two states or provinces is not considered border malaria. Countries, so when we talk about border malaria, the definition is, as currently interpreted, restricted to international borders between two independent sovereign states. What about between a state that is local transmission free and a joining state? Does that not fall within the definition of border malaria between those two states, for example?
Thank you. I think the border malaria definition is it speaks about two countries under the sovereignty of two political entities, and this within one government, and there's a border and like provincial border and or what is border between two states under one political entity. We don't call it border malaria because this is now about international coordination. There should be a coordination mechanism in place, which is similar to the border malaria, but this is under one government and we don't expect international coordination. And I think countries should also establish the coordination mechanism within different states or within different provinces to solve these issues similar to border malaria. Thank you.
Yeah, thank you, Dr. Lee, and thank you to our audience members for the interest that you're showing. We have a few more questions, but we really need to move on. I'm sorry about that. We need to move on and give our other speakers opportunity to speak. What I would like to ask, because there's some very interesting questions from Messiah, for example, and so, Dr. Lee, if you don't mind, would you mind having a look at those questions, and maybe you can frame a concise summary response to that? Type in the answer in the question and answer box, if you don't mind.
Okay.
I think our audience would be very grateful for that. Thank you for that.
Thank you. I'll have a go. Thank you.
Thank you sincerely for a very, very important and interesting presentation, Dr. Lee. Sorry, can I also just ask, in the bio sketch, I mentioned that you're leading an evidence review group on border malaria, which is an extremely important topic in Asia. So I wanted to ask if your group has produced any written guideline recommendations or findings that our Asia community can download and read. If your group has come up with manuals, guidelines, or something that our vector community here can download, maybe you can just pop that into the chat box so that people can access and download that. Thank you for that. So
yeah, I'll send a link to in the chat box on border malaria, the ERG border malaria meeting report. I think it might be useful.
Wonderful. We appreciate that. So still on the now we've had the broader picture around border malaria from Dr. Lee as a WHO expert. Now we're going to go down to a practical example, a real life practical example. And this talk is going to be by Dr. Prayut Sudatip, who is Deputy Director in the Division of Vector-Borne Diseases of the Department of Disease Control in Thailand. And Dr. Prayut is a public health specialist with a doctoral degree in public health from Kentucky University in the USA. He has led the planning, implementation, monitoring, and evaluation of the Thailand malaria elimination programs and global fund programs, the regional artemisinin resistance initiative, RI2, RI3E, and also RI4E grants in Thailand. He developed the Thailand National Malaria Elimination Strategy for 2016 to 2024, and he also leads the implementation of community-based malaria services, cross-border malaria elimination, malaria posts, and the malaria elimination surveillance system in Thailand. So clearly a very big and important portfolio of responsibilities. Currently, Dr. Prayut collaborates with PATH and USAID PMI to expand the role of village health volunteers in malaria services. And additionally, Dr. Prayut also works with the University of California, San Francisco on sustainability and integration of malaria activities into the broader health and local authority in Thailand. He also works with MMV to assess the feasibility of radical cure for P. vivax. Professor Jetsimon, if you're still listening, you should find, you're almost certainly well aware of that already. Dr. Prayut will talk to us on evolving cross-border malaria challenges, impacts on Thailand's malaria elimination efforts. So from all of us, Dr. Prayut, we appreciate you making time in your busy schedule, putting together this presentation for us. Over to you. Thank you, Dr. Prayut.
Good afternoon, everyone. And you see my screen?
Yes, thank you. Looks good.
Okay, all right. So thank you, the organizers, for giving me to present the update on malaria elimination in Thailand and the challenges that we are facing currently since we implement malaria elimination in 2017, 6 years ago. So this is Thailand malaria elimination strategy, which is we aim to eliminate malaria by 2024, which is next year. But we aim to eliminate falciparum by this year, 2023. So our strategy comply of 4 strategies, but mainly will be to accelerate malaria elimination in Thailand, and which is we apply real-time notifications, investigation and response, which is WHO called 137 strategy from China, and also improving diagnosis and treatment at the community levels, especially along the border, and do more active case fighting and improve insecticide treated net in endemic area to cover at least 90% of households in the endemic area. But in 2021, 5 interventions were added, including rabies prevention of reintroduction strategy to prevent re-establishment of malaria in malaria-free area, and set up outbreak response system along the border, especially in Myanmar border, and accelerate PF eliminations, because at that time we have a few cases of PF, and also implement school-based interventions and people-centered approach added in 2021. And another strategy I would like to highlight is to extrabit the national and international collaborations, because Thailand shared border with other countries and that a lot of partners working on malaria eliminations in Thailand too. So in this strategy, we try to improve collaboration of partners to involve in malaria elimination, especially sharing of the investments and resource to eliminate malaria. And the last strategy will be to promote community to be able to self responsibility in the communities. So this is our strategy. This is the malaria situations from 2018 until now. So this is the showing that we have off track of malaria eliminations since 2021. And after the COVID-19 release and the conflict in another countries, so the case in Thailand start increasing since 2022 until now. So we have an outbreak and along the border currently. Not only the total of cases that we are off track eliminations, but also falciparum here. Since 2013, we detect nearly 17,000 PF cases, but in 2021 we have only 69 cases. But since then, falciparum case increased nearly 600 cases this year already. So we are off track of malaria elimination and also PF elimination in Thailand too. So this is the total of cases in Thailand since October last year. Thailand detect more than 15,000 malaria cases, which is 2 times higher than last year. And the majority of cases are from Myanmar border in 6 provinces, but the highest provinces is in Tak province and Mae Hong Son and Kanchanaburi province, the one that in this slide. And more than 55% of total cases are migrants from a neighboring country. We identify only 45% of total cases are Thai residents. And the majority of cases are Vivax, account for 94% here. And mostly are male adults who work in the forest. But the problem is that we detect more than 27% of cases are children under 15 years old here. And of the total cases, about 61% of cases are indigenous case infected in Thailand. And we also have increasing of active foci compared to the last year. In this year, we detect more than 800 active foci or active foci villages already. And unfortunately, we have 4 days since October last year. So this is the interventions that our government provide for to respond to an outbreak along the border. We have 6 interventions actually, but the main of intervention will be encourage or involve village health volunteer in Thailand to do more proactive case detection using RDT and do more supervised treatments because the most of the case in during outbreak along the border here are mostly Vivax. So compliant to 14-day primaquine is very critical in to respond to an outbreak here. So we in this strategy we'll try to involve village health volunteer to do quickly test using RDT and do more supervised treatment in the village. And since the outbreak here is between Thailand and Myanmar border. So we work with the CSO and Myanmar governments to expand diagnosis and treatment service across the border. But the problem here, Myanmar government, they not be able to provide services near the border. So we will rely on CSO to do test and treat in Myanmar side, similar to the Thai side, which is we already have malaria post along the border in Thailand here. And also we try to improve coverage of vector control to nearly 100% of the household in the endemic area and respond to foci completely, appropriately, at least 100%. And we will use our information to monitor the intervention to provide to those endemic area. This is a strategy that was approved by the communicable disease committees in Thailand and been implemented since April this year. So since then, we see some reductions of the cases actually. This is an example of the foci along the border that Dr. Lee described, but this is more very local actually, but in Thailand we call border foci, which is the, it's similar foci when we implement the response to foci, we not be able to do only in Thailand, but I think to be better to control malaria, we need to control both sides of border, similar interventions actually. Otherwise, the transmission will continue as Dr. Lee explained here. So in Thailand, along the Thai-Myanmar border, we identify nearly 100 villages share border or share foci here, which about 100,000 of habitats in another site in Myanmar, which is the Myanmar government not be able to provide services in those areas. So the interventions or services along the border here, the habitats in those foci, they rely on services in Thai side only. So this is difficult for us to focus the RDT or prevention measures to provide to populations who cross border or stay in the same foci but in different countries like this. So, but this is the figure that we went to the fields. Actually, you can see that along the border is not border, is natural crossing point. People along the border, they are relative. Actually, they be able to cross border to visit their relatives, or even the children in Myanmar side, they cross border to school in Thailand and living in Thailand during weekday and then go back home during weekend and come back again. So this contribute to the persistent active foci in Thailand. And also people along the border, they share culture, they share land too. So people in Thailand, they also have lands in Myanmar. They cross border to work in Myanmar to grow crops or other plants, and then bring malaria back to Thailand. And also people from Myanmar, they cross border to work in farms, in croplands in Thailand. So that's the make transmission persistent along the border and difficult to control, and resulted in an outbreak here. So in Thailand, I would summarize that the progress malaria eliminations was on track until 2021, when we have an outbreak occur along the Thai-Myanmar border due to the movements from Myanmar and political conflict in Myanmar in the last few years. So this resulted in an increase of the case. And if something continues a similar pattern like before, then we will have a difficult to control an outbreak along the border. We cannot do interventions only in Thailand. Currently, the interventions we done properly only in Thailand, but foci, similar foci in another Myanmar or in another neighboring country, we will not be able to provide services due to security issues, because there are a lot of fighting in that area. So we need to do very well contingency plan, which is very difficult because the situation is unstable. We don't know when there will be conflict in another site and how many people will migrate cross border to Thailand for securities. So this is very difficult for us to procure or to do contingency plan in this area actually. So it's also difficult to manage RDT or the anti-malaria stock, because the very unstable things, and also the 137 strategy, real-time reporting, investigation, and response. It's very difficult to do that because it's unstable area and is a security issue, as I mentioned before. And to manage foci properly, we will need to approach we call foci beyond border, mean in the same foci, but in different country, we will have to do the same, as Dr. Lee mentioned before. Otherwise, the transmission will continue in both sides and not be able to reach malaria eliminations. And since in Mekong regions, migration is very easy, and people from endemic area may contribute to re-establishment of malaria in malaria-free zone area. So we will need to keep our surveillance very strong so that we can prevent reintroductions in the area that malaria already declared free. So this is the most, I think, difficult for Thailand. And we will have a lot of work to do and to work with neighboring country and partner to eliminate malaria along the border of what we call, I like the term, malaria, border malaria, which is very difficult to control and eliminate here. So this is my presentation. Thank you.
And we thank you, Dr. Prayut, for a very detailed, very clearly presented talk. It's a very worrisome situation that you've clearly explained. You know, border malaria is a problem at the best of times, but Thailand is now, you know, on top of the normal challenges. There's the challenge of unstable and unpredictable situations on the other side of the border. And who knows how long that is going to continue. And it impacts on Thailand's objectives for malaria elimination. You've shown how the number of cases have surged after 2021. So we wish you and your program all the best, knowing that you're doing what you can. Very challenging, difficult situation. We're going to move on to our next presentation, and I'd like to ask the audience, please put any questions you have for Dr. Prayut, put it in the Q&A box, and we'll get to those questions after Dr. Pradeep has given his presentation. I think we are very close to losing Dr. Lee. I think she has to leave very soon. So Dr. Lee, again, for your participation and contributions to clarifying the questions, sincere thank you for your participation.
Thank you.
Thank you. So remember, audience, please, questions for Dr. Prayut in the Q&A box. Our final presentation is going to be by Dr. Pradeep Srivastava, who's very familiar. He's a very familiar and respected figure in our various APMEN activities, whether in webinars or short courses. We've all seen him many times. He's a strong contributor to our APMEN activities. Dr. Pradeep is going to talk to us on the topic of vector control decision-making across complex mosaics of urban, rural, and varying transmission intensities and geographies in India. Dr. Pradeep Kumar Srivastava was head of the Vector Control and Entomology Division of the National Vector-Borne Disease Control Program in India until his retirement. He headed the Planning and Coordination Division of the India National Vector-Borne Disease Control Program. He was in charge of urban malaria and the National Filariasis Control Program. He has worked as advisor to WHO on many occasions in member countries of the Southeast Asia Regional Organization and WHO headquarters in Geneva. He was a member of the Indian delegation to the Conference of Parties in 2017 for DDT reduction and vector control. He developed the state-specific malaria elimination plan for Jharkhand state with WHO support in 2019. He has more than 50 scientific publications to his credit, and also many guidelines, including the operational manual for integrated vector management in India and chapters in various books. Just to mention also, he was bestowed the Vestergaard Fransen Award in 2019 by the National Academy of Vector-Borne Diseases in India. So clearly, a man with many decades of high level and also hands-on experience. He can talk to you on get your hands dirty at ground level program implementation to high level policy issues with equal ease and depth of knowledge. So we are privileged to have you join us, Dr. Pradeep, and we thank you for your time. So over to you, Pradeep, please. Thank you. Thank you.
Thank you very much, Leo, for a elaborate. I do not know whether I deserve that or not, but anyway.
You deserve it. Don't worry. You deserve it.
Is it okay? Is it visible?
Thank you. Yeah, please go ahead.
Okay. So the topic was given a little more complex, that mosaic geography in India. We have been hearing last two speakers giving a lot of problems and a lot of questions also. We have been hearing this border and cross-border, international cross-border malaria elimination. And let me go through the Indian scenario first. If you look here, the whole country, there are different diseases prevailing in different. I have just listed those 6 vector-borne diseases which are being managed with a national program, but there are some more diseases like scrub typhus and KFD and other diseases which are also emerging and reporting across the country at different parts of the. So the problem is much more complex when you are not dealing with only one disease. Though many of the examples we will be quoting only for malaria, but for vector control, it may go along with that. Now, if you look for Indian scenario, this is a paper published long back, and 10 years data consecutive for 3 years. If you look in Indian scenario, if you see the whole area which the endemicity, it is concised here only. It is restricted here only. See, 10 years, 80 till 90, then 2000. Now, if you go through the geography of the country, and if you see the area which has been given in different scenario, this is the dry belt, which was yellow color. If you see on the left hand side, A, this is a dry belt completely. Then slowly the changes has happened. The xeric shrub that is in desert area, when the shrub and this is only the rain-fed area. But now you see, slowly in 2020, 2025, it is estimated that the whole area will become the wet. To go little more, if you look on the forest area clubbed together with disease scenario, and then the climatic condition and the topography of the area, if you see the forest land, you see the forest land, darker area is more dense forest. And see, if malaria is prevalent more here, red dots, if you little enlarge these figures, you will see the smaller dots with a smaller intensity and bigger dots with a bigger intensity. These are the papers which have been published in 2023. Now, if you look on this old maps which Indian they have published, our previous scientists, they have published this data. This is published in 1996 booklet. This is a big booklet on malaria in India. Dr. R.S. Sharma was the director. Now, if you see, the green area is basically the endemic area which is vulnerable, where you may get little bit. But this red color area, this is basically the high malaria endemic zone. Again, if you correlate with the previous slides, this portion comes, the central portion comes as it is. And the blue area also, it is an hyper endemic area. You may get, and this particular dark brown area, this is basically a Punjab area, and this is an outbreak prone area. Now, since 1996, so many places have changed. If you see the analysis in geography along with the climatic factors, if you see the area of India, this is the temperature, and down below is the humidity, relative humidity. If you see that temperature is also changing, coming to the ambient temperature, whereas this is 30 years, 2030 prediction. This is, again, if you see the relative humidity, it is also, which was earlier here only, now it is coming everywhere. So, because of intermittent rains and persistent rains, it is not only concise, only 3 to 4 months. So, the relative humidity, this is a prediction for 2030, where we are targeting for malaria elimination. So, the vector-borne diseases prevalence is going to be much more what is we are anticipating. Because the congenial atmosphere, or the term which she used, Lee, entomological receptivity. We have been using only receptivity, but this is a better term for entomological receptivity. It is increasing day by day. Now, based on all those things, you see, the earlier publications, they have classified, if you see the vector influence in different area, arid zone, semi-arid zone, and deciduous wet zone, or deciduous dry zone, this is basically dominated by Culicyphesis and Fluetilis complex. Then this is Stephensi, in fact, with the urbanization increasing everywhere, and then Culicyphesis. But in the northeastern states, you see Dirus minimus and Fluetilis. Dirus, now it is known as Bimai complex. And the coastal area where you get Sandicus, now it is known as Epiroticus. So India is already under the clutch of 9 vector complex, which is established primary 6 vectors and 3 secondary vectors. Now, if you see the endemicity of malaria, though we have done significant progress has been done in India so far as endemicity malaria cases reduction is concerned. If you see, these are the maps for 2000, 2015 and 2017. And the latest one, if you see the red color marking area, it is basically malaria map is shrinking slowly. See the red color and this green, and slowly it is all getting converted into, except this 2021, if you see, only part of the 2 districts or 2 districts only are in the high burden area, which we call it as a. Having known this dynamics of the total topography and different mosaics of the land scenario with the climatic conditions interplay. Now, if you see what are the basic challenge, our basic strategy for vector control is only IRS or LLIN. In urban area also, it is primarily based on insecticide related, though we call it as a source reduction and environmental manipulation, modification, but how many places it is being done? So, IRS, the basic challenge is the resistance, and this is a global threat map produced by the WHO. So this red color zone, all this area confirmed resistance. We don't have many insecticide in our basket. Based on that, if you look on this, if you see, if we try to classify the different paradigms, how to control in that area, we have been doing only on epidemiological basis, please note it. So what is the agriculture or irrigation related malaria? This is another paradigm. Forest malaria, tribal malaria, we just heard about that. Malaria in urban or peri-urban area, or industrial or project malaria where township develops. Desert malaria, just a minute. Sorry. Tribal malaria, malaria in peri-urban area or industrial township, desert malaria. Then we have a coastal malaria. We have cross-border malaria. I will little bit more elaborate on that because many of the things have been elaborated by head. But in India, we consider both inter-district, interstate, and international borders. Malaria among migrant population. Even beyond this, also there are special situations which we face. Floods, outcome after that, flood recedes, then social civil disturbance area, then malaria and climate change. These are our very important things. You see, have a glance on malaria with irrigation, irrigated lands. Even malaria with irrigation, we can classify agriculture related in 3 categories. Irrigated, everybody knows, we all know that Culissifasis or any other vectors which will breed here and they will be creating a havoc on persistent transmission of malaria. They are all. But non-irrigated agriculture malaria also like cotton plantation or tea garden where aggregation of people, which is not exactly migratory population, they have settled there. They have come from endemic area, but they have settled for years together. They are working there. So that workforce is there. Tree plantation malaria. That is again the same thing. You go for rubber plantation or coconut tree plantation or at the cutting time or at the fruiting time, but then you collect lot of laborers there. So there is a focus of malaria. If you look on the forest malaria, which is a major challenge now with the outdoor transmission, because mosquitoes are also, there is an ecological succession and there is a change in mosquito behavior, vector behavior. It can be classified deforest malaria or forest fringe malaria. Deforest malaria also, you saw people, they are going for gem collection, gold or mining collection, hunting malaria. I mean, they go for hunting purposes. They stay there whole night and they are being bitten. Food gathering malaria, which people, they go for collection of some fruits and other things. There is a forest settlement. There is a regular forest activity, which they inside the forest, there are people who are settled, there are inhabited villages are also there, which forest has encompassed in that, and the forest people, forest officers, they take care of them. They are also having very good interconnections with them. They have got society, local society, forest society also in that, their representation is there. Then there is a forest fringe area. When they are cutting border of the forest, they try to settle and they try to do some cultivation, which is basically a shifting cultivation. In India, we commonly call it a zoom cultivation. Then there is a resettlement colonies, or they go for animal grazing. So if you see, there are different kinds of vectors, very potent vectors. Minimus breeding is found. Dirus breeding is found, the jungle breeder. And then there is an highland malaria also. We have seen even the Stephensii or the minimus, we have seen at highland high level malaria. This is very, very difficult situation. Then you see another tribal malaria, which is more or less related with forest, because many of the tribal colonies, they are located in the forest area. See the situation, the kind of the living habitations, how you will go. It is not good for absolute coverage of spraying, quality spraying. People, they cannot use, many of the times they cannot use inside the huts, they cannot use the bed nets, LLIN or ITN. So they have to sleep most of the time, they sleep outside. So this is basically mix of indoor and outdoor, four combinations: exophilia, exophagy, or endophilia, endophagy, or vice versa, endophilia, exophagy. So this is big challenge tribal population with the forest malaria or forest range malaria. This is major chunk of the problem. Urban area, most of the people nowadays, it is a big issue of Stephen's eye invasion. From when we have been struggling in India since 1971, when we made a complete plan for urban malaria, but who are all working at the ground level? The basic challenge remains that whether quality work is being performed. So urban malaria, outside urban, adjacent area, peri-urban area, it is two influence basically, Stephen's eye or cholecystophasis, or in foothills, it is Stephen's eye plus fluatilis. So these are a big problem. How are you going to do it? Industries are coming in and around cities. There is a lot of aggregation and there is no facility for proper cleaning or proper sanitation facility. Now look here, this is one of the biggest slum in India. How you will go? You cannot walk also properly and think of doing the prevention and vector control activities. Or if there is no water supply proper, you see how people have to store. They are actually forced to store waters. And that is the inviting the Stephen's eye to come and breed inside. Desert malaria is another big issue in Rajasthan area, desert area, which you have seen the arid zone. Now there are takas, there are wells full of Stephen's eye, so you have to hermetically seal. Or if you see certain area where there is a oasis farm, so people they do go and settle there only. So this is another big problem for that. Now, coastal malaria, we normally see if it is a mainland coast, it is not Sundicus, it is basically a cholecystophasis breeding, and that people they sleep outside, or there is a clear-cut demarcation in high society and the fisherman colonies. So where they usually they sleep outside near the seashore, bitten by the mosquitoes, and then they try to go for fishing in the early morning hours. So they get malaria or they get transported. This is another issue where the people are sleeping just like that. So this is basically a different geography, different paradigms of malaria problem in the country with the different topographical situation. But the basic question is cross-border malaria, which there was issues. Why it is important, she has already explained. I will not explain that because international transfer, but we have been listening this thing for the last 40 years that both the sides, they should synchronize the vector control process in terms of time and space and in terms of material. But because the decision making authorities are different, it is just not practically possible. Second thing, though program says that there should be an integrated collaborative approach, but it has been restricted only for some meetings, some advices, some suggestions. Outcome of those meetings, outcome of those intercollaboration meetings need to be practically prioritized, and for that there should be a group of experts, or they say policy makers should sit together and they should come forward, then only it can be taken into the play. And as she has also told me that different boundaries, different borders will have different problems. So different problems will need different tailored approaches. Now I'll come to the issues. Last one is migrant malaria. There was a question also that migrant and imported. Migrant malaria is basically when people are coming and it is to be proved that this is a migratory malaria. This is because of the flocks which is moving from one endemic area and they are screened and they are contributing to the malaria outbreaks or this thing. Whereas imported malaria is taken one from the migratory or one from the cases are not there and suddenly one case is coming through the migration, that is known as imported malaria. Now the basic issue is migratory population, they are settling. So they become a focus for the asymptomatic malaria cases if it remains undiagnosed, or symptomatic malaria if they are coming, they will be screened immediately and given the treatment. So basically these malaria outbreaks, they are attributed to, I mean, we try to take excuses that it is because of climatic changes or vector propagation or lack of facilities. But how long we will go on if we are targeting malaria elimination? We know that we have vector control tools limited. These are the only vector control tools which is being run in any of the national programs. Either you are doing source reduction, or you are doing larviciding using fishes, using chemical larvicide, using insect growth regulators and biolarvicides, or you are doing anti-adult measures either with the LLIN, ITN, or spraying indoor residual spray, or to some extent fogging to contain the outbreaks. Then capacity building, advocacy and sensitization you are doing. In addition to that, what else? There is nothing actually in our basket. So with this tool only we have to do. This is very, very important. Now, if you see this tool, what we have done, the whole country, on the basis of those geography and paradigms and malaria endemicity, it was divided into 3 categories: high, low, medium. Now, if you see the high category zone, that red color marked area, what activities are required? You have to do all source reduction, IRS, if not covered with LLIN. LLIN is not given every area. It was a prioritized vector control measures right from the beginning. But wherever LLIN, it is universal coverage has to be achieved. Larviciding, biological control, environmental methods, insecticide resistance monitoring, so that you can take decision for switching over the insecticides, and entomological surveillance. But when you come to the group 2, moderate endemicity, 2 rounds of IRS if it is required, larval source management, because most of the areas LLIN will not be there because it was a prioritized initiative of malaria control or elimination. Then insecticide spraying will be focal, restricted to the focal during outbreaks also. Advocacy and entomological surveillance will continue. Whereas in the low endemic area, if you see, the spraying and LLIN is not there. The rest, all the activities are there. So these are the basic tools which are available in the program. It is being done. Now, basically, when you land up in control, prevention and control area, what to do? Breeding sites, you have to do all these A, B, C, D, E, F, G. That is draining water, covering storage container. We all know the methodology, cleaning, and then. So this is one methodology which has been given. Mosquito breeding at construction site, there is a separate control measures so that you can involve them, the contractors also, the proper designing of the construction overhead tanks so that as defense eye or industrial township, there is not aggregation of the storage of the waters. So openly it is not stored, so that it's not that. Air and seaport surrounding area, we can do control measures, but there are certain restrictions because they are all prohibitive area. So the general health workers may not have the regular entry. So you have to train them and tell them to what to do within the inside that area. Adult mosquito density, yes, we know that quality IRS coverage or universal coverage, and then focus on vulnerable groups. This is very, very important. Then these are the innovative things, protection from mosquito bites, community participation, or establish a vector control units for vector surveillance. These are all important things, but practically to some extent, somewhere it is done, somewhere it is not done. When you reach to the elimination level, I mean, this is a transition from controlled pre-elimination to elimination level. You divide the area and see which area has gone to I mean, basically it is a narrowing down the area. You are prioritizing within the elimination area, which is high, which is low, which is moderate. And then you try to figure out what is your vector surveillance data, what is your total focus, how much quantity you required, and how best you can do within the available tools which I have shown. Same is for the elimination. It has to come as a sustained movement for, and first thing, it has to be known everybody. It is everybody's responsibility. Now government has done something which everybody has to sustain. Otherwise you can't go on creating, and then the last presentation which we have seen, that 2021, it was there, and suddenly there was a increase in the malaria incidence in Thailand. So this will come. We have also burnt our fingers. We have seen same story in 65 when there was no death and less than 10,000 cases, and suddenly it rose to 6.7 million cases in 77. So these things will be retained as it is. Summarizing the whole thing, the lowest category, we have to see what activity we are doing. This is based on malaria endemicity categorization, the vector control actions that you have to map the potential breeding sites, start from the larval, then go to the adult.
Pradeep, can you hear us?
Employment protection scheme. So these are all the things available. Sorry. Then the high category is you have to do LLIN and all health centers covered with 2 rounds if it is qualified, if it is not qualified. So these are different paradigms, different scenario, different geographical situation. We have to work on that. That is what was my topic, and I conclude here. Thank you.
Pradeep, thank you for that very thorough overview of malaria control in India. India, as we all know, is a vast country with very different varying conditions and different challenges. You explained that very well. And India definitely is a prime example of malaria control in a very complicated, complex variety of situations. Plus, on top of that, of course, you have an awfully Stevens eye, urban malaria, which adds a whole different paradigm of, transmission as well. And very, very different breeding sites to what most people are used to. So we should be congratulating India for doing an excellent job. Thank you for that so much, Pradeep. Let's take some questions, if you don't mind. We're running a little bit over time, but there's a question here from, what happened to the question? There's a question from Dr. Susanta Ghosh. He had a question on, maybe it was answered by writing.
It was for Lee, basically, or cryptic malaria.
Yeah, but he also posed a question to Dr. Prayut about if the use of, it's a general question, not specific to border malaria, if the use of LLINs had impacted on changes in vector behavior. So I don't see that.
It's been answered.
It was answered. Okay, so let's move on then. Thank you for that, Wulan. So here's one from Mohammed Khalilur Rahman to Dr. Prayut, I suspect. Other than LLINs, what control measures are Thailand taking specifically in the border areas, to achieve malaria elimination? Can you just give us some guidance as to, how does Thailand approach malaria control, specifically vector control, generally, and in the border situation, Dr. Prayut?
Yes. In Thailand, the first strategy that we use to do vector control is the insecticide treated nets, actually. So what we mean 100% mean every household have insecticide treated nets to cover 1 net per 2 people. So we aim to have 100% on that. And for migrants, we will give them 1 net per 1 people because they move around. So they will not be able to to quantify like 1 per 2 actually. So every migrants who we can reach during we do active case detection in communities, or they visit the health facility, they will receive long-lasting insecticide treated net 1 to bring home actually. So and for like children from Myanmar who cross border to study in Thailand, what we plan to do this year, when they go back home, we ask them to bring net back to their family so that we can cover some families in another side of Thailand. Actually, that what we plan. And for persistent active foci, our staff will do residual insecticide spraying for the focal spray or something like that in huts, in the farm, in the like crop area or something like that. So the majority of vector control in Thailand will be insecticide treated nets.
Thank you, Dr. Prayut. I'm very happy to hear that you are providing the migrant people with LLINs. It must be a very complicated process because it's difficult to predict the numbers and they vary. You get surges. So well done. Well done indeed. So I'm going to try and ask Dr. Prayut a question and then ask Dr. Pradeep a question and then go back to Dr. Prayut. Let's see if we can answer a few questions that way. So there's a question from Mohammed Asif Mahmood to Dr. Pradeep, I think. And he's asking about intermittent irrigation in rice crops as a means of larval control for calicipacies, or is that an effective way of larval source management by intermittent irrigation in rice crops, Pradeep?
I think the project is not here. Might because of the internet connection.
Okay. Dr. Prayut, can you see a question there that you can respond to?
I'm trying to unmute.
Can you repeat? Sorry, I didn't see that.
Yeah, the questions I see here are mainly for Dr. Lee, and there are some for Dr. Pradeep. I'm struggling to see one here that we can put to you. Maybe try this one, Dr. Prayut. It's from Mohammed Asif Mahmood. Is there any universal protocol or WHO guide for prevention of imported cases of malaria? I suppose it's the same as how you treat imported malaria is. Any comments on imported malaria?
Yeah, I will try this actually. We have import case, but in Thailand we do recognize the importations and how to prevent re-establishment. So in Thailand we start implementing POR, actually prevention of re-establishment of malaria in malaria-free areas. So we train the provincial staff in malaria-free area to have a POR plan and implement POR plan to prevent the indigenous case from importation cases actually. So, but I think the highlighting would be how to detect case and respond to the index case quickly to prevent ongoing transmissions. I think that would be the best way to prevent the reintroductions of the case in malaria-free zone.
Thank you, Dr. Prayut. Thank you for that. Pradeep, let me ask you, there's a question here on what is the impact of intermittent irrigation in rice crops as a technique for vector control? Is that practiced in India? How do you go about dealing with larval source management in rice fields? What would you recommend?
Basically, intermittent irrigation in the rice field area has been recommended for the farmers only for control of JE vectors, Culex Stridner group or Vishnoi group, basically mosquitoes. For malaria, basically for Culex and later part, it is supported with annularis. Now, though it is given a recommendation, but it is not practiced because that particular season, it is basically the malaria endemic area is covered with the insecticidal residual spray operation. So those 5 months, which is basically that crop protection area, it is actually already under umbrella of IRS.
Thank you, Pradeep. So, Dr. Prayut, I am struggling to find a question here for you. So I'm going to ask you one that was actually directed at Dr. Lee. And now I've lost it because how do you address the movement of people and goods across borders as a factor in malaria transmission? So let me broaden the question. The situation along the Thai-Myanmar border, is it general movement across a wide area, or is it channels that people can come through particular routes where you can station a malaria post where finger prick samples can be taken and medication can be provided, which makes it a lot easier. How does it actually happen? Are these migrants moving at low density across a very wide border area, or are there clear channels where it makes it easier for you to apply malaria testing and treatment? Just some comments around that. And if you do that, do you have malaria posts at those crossing points?
Yeah. So I think we have both actually. They have certain route for them to cross. If they have same village, you know what I mean, border foci, it's like another half of village in Thailand and another half of village in Myanmar that they have very permanent route, and then we easy to provide services in those villages. But in another situations, we have like highly movement with no certain route or pathway to go. This kind of population is very difficult to control and provide services. Some of them may like stay along the border one night, and then another few hours they may in Bangkok or in near Myanmar, Cambodian border to work in fruit orchards or rubber tapping, something like that in another site. And another a population which is very difficult to control is like refugees. When they have fighting in another side, they will move to Thailand a few days actually before in another site stable, and then they will go back to Myanmar where they house. So in these populations, we have difficult to provide services too. The best way for us to do is to provide test and treat quickly if they have symptoms actually, but we not be able to provide insecticide treatment for them because it's very quickly situations. They come few days and we're not prepared enough. So I think in terms of to solve the problem and to provide services properly, we will need to do contingency plan, not only Thai governments, but we need international collaboration to do that, because this is a special situation along the Thai-Myanmar border, actually. Yeah, so that's what I can respond. So,
No,
but if,
yeah.
if they stay in the farm, work in the farm, we can provide services. We can do test and treat for free. We can give them long-lasting insecticide treated nets for them to protect themselves. Yeah. Okay.
Thank you for that, Dr. Prayut. Question to both gentlemen from Wichai Satimai. Do repellents play any role in malaria elimination? You've responded to this question before, Pradeep, so let me ask you first. What's your comment on the use, your opinion, and the official WHO decision around use of repellents?
Thank you. I mean, I was also looking for there were two questions, one on drones and one on the
Yes, that's right. Yeah.
I'll send that. But to give the answer for this, clarify this role of repellents. You know, repellency in the program, it has not been included. There are many reasons. One is procurement, one is frequency, one is supply, logistic chain management. Second thing is that they are all registered under a different act. There is a two acts, Central Insecticide Board Act, and there are another one is Drugs and Cosmetic Acts, which are available in the market. So when we write the guidelines, we do recommend that people, they can like wearing full sleeve clothes for dengue. Does not mean that we are going to supply full sleeve shirts. So similarly, the repellents have been advocated, but not as a supply items, commodity to be supplied under the program. So repellents are there. It's a good tool, and people, they can use it.
Yeah, yeah. No, thank you, Pradeep. But WHO has a different opinion. It does not, you know, again, it's people can use it, but there's no evidence that it has an epidemiological impact at scale.
That's right.
So, yeah. So,
basically, the reason is WHO will say only when it is a multi-country trial and the manufacturer, they have to approach them. They have to go for this, sponsor that project, and it has to be tried in at least 6 or 7 countries as a multi-country trials. And then the data is generated. So evidence is generated, then only it will come either on rejection or recommendations.
Thank you.
May I clarify a little bit on drones technology, which somebody has asked?
Sure, okay.
The drones technology, recently also there was a publication. Basically, it is you can use it as a tool for entomological surveillance, breeding sites mapping, and location mapping tools. But as in agriculture, they have tried, it has not been recommended under the program for overall spraying in the as a larvicide in a smaller area, because you have to fix up lot of things. What is the discharge rate? What is the nozzle? What kind of force will be there? What is pressure? So these are all validations is not yet done. We heard that there are some companies, they are going for some validation using the helicopter spraying or aircraft spraying. It is they are doing, but that can be taken only as an outbreak control measures. But as on date, it is only taken as a it is just being considered for the larval source mapping equipment, not for the vector control tools.
Thank you.
Another clarification was asked by one of the persons that what is the role of cross-border malaria issues if it is imported. The basic importance of cross-border, why it is now being highlighted, because once you are approaching to elimination phase, you are claiming that there is a zero indigenous transmission. But if you don't monitor, the cross-border malaria, which I am preferring for international cross-border malaria, then even with one imported case. So you have to be vigilant, and two things are very important: vulnerability of the area for people's migration, receptivity of the area for the vectors. So these two things, if they are taken care of in the area which is low endemic area, it will be very, very important tool. And that is why the cross-border malaria is basically giving that full importance. Thank you.
Thank you, Pradeep. So our last question, unfortunately, because we are now way over our allotted time, Dr. Prayut, if I could ask you a general question, if you don't mind, because it's something many of us are trying to understand. You know, in those border areas, if you have 100 people presenting with fever at a health facility, you know, a certain percentage of them will be malaria. And then the rest, you know, what is the underlying etiology or cause of fever for non-malaria fever cases? Is it predominantly arboviruses? You know, any idea about what are the other contributing factors to fever among presenting patients?
Yeah, but we work in malaria, so we assume that fever will be related to malaria actually. But in fact, along the border or in remote area, so many things actually. But in Thailand, dengue outbreak here now also very, very intense in Thailand currently. And I think in remote area also scrub typhus also play critical role in this too. So when we our instructions for malaria clinics, when they have negative for malaria, they need to refer patient to hospital for other evaluations or diagnosis with other disease such as dengue or scrub typhus or even leptospirosis. Yeah.
Thank you.
Many, yeah.
I'm going to ask one last question, Dr. Pradeep, from Rajpal Yadav. Are there areas in India where a combination of LLINs and IRS is practiced by the National Center for Vector-Borne Disease Control? Any places, and for what reason would you have combination IRS and LLINs?
Yes, it is. It is in many places, even in Odisha, even in northeastern states, it is done. The basic reason is that if you don't attain universal coverage, absolute coverage with LLIN, initially it was there, you cannot suspend IRS immediately. And we have got good impact with both. Though now the recent guidelines, which we have been doing it since 1997 onwards, use of BedNet plus IRS. Recent guidelines of WHO that we should avoid the same kind of insecticide which are used in LLIN with the IRS. But what is the options? We have got only synthetic pyrethroid. And at different platforms, I have tried to clarify this, that insecticide supplied for IRS is having 2-year shelf life. For a smaller area, it is okay for logistics pattern. But if you procure the insecticide for 2 years shelf life, it takes 3 to 5 months to reach to the destination. You use for the next 2 years and next round and next round. So you can't go on rotating to avoid the insecticide resistant precipitation. The second very important thing, there is no evidence that after how many rounds of spray with LLIN or LLIN alone or IRS in the field, the 90% and 98% above resistance we are achieving. So the number of years is not counted for that particular year in the field condition. So we have been using and we are okay with the program, but we are also trying to phase out the dependency on IRS slowly, because LLIN once applied, it will be there for 3 years. So we have already curtailed from 65 million area covered, population covered under IRS. Now it has come to around 25 to 30 million population.
Thank you. Dr. Porn or Wulan, may I ask if you can screen the poll questions while I take time to express sincere gratitude again to Dr. Prayut and Dr. Pradeep for wonderful, very interesting, very thorough, very detailed presentations and discussions. I think our audience members, we thoroughly enjoyed it. We learned from your knowledge and you shared it very well indeed. So a sincere thank you from all of us. I would also like to express my gratitude to Dr. Porn at APMEN Singapore headquarters and also Wulan here at Malaria Consortium in Bangkok for your excellent technical support, making sure that there are no problems. So to our audience members, you've been very patient and persistent and stayed on till the end. We're very grateful for that. We hope you enjoyed it. Thank you for joining the webinar, and we'll see you in a couple of months with our next webinar. So to everyone, sincere thank you for participating in this webinar.
Thank you.
Thank you so much.